Hi, this is Paul Cook with the University of Colorado College of Nursing, and I'm going to talk to you about different approaches to nursing science, some of the similarities and differences between quality improvement, program evaluation, and research. Now, these are important distinctions because different rules and regulations apply to each, different sorts of methods are used in each of these approaches to science. But if you look at these definitions, which were gathered from knowledgeable sources, you can see it's not completely clear how they differ from each other. So if you look at the first three on here, you see the word systematic in all three of them. Clearly there's something going on here about data. Clearly there's something in here about knowledge. But if you read these, you may not completely see from these definitions themselves how these activities are the same or different from one another. And these things matter because our science is advancing very fast, and people want to be able to publish results from quality improvement activities for the very reasonable reason that they feel their colleagues would benefit from this. People are using more complex statistics in all kinds of science these days. It's a lot easier to do that. People used to argue that QI was sort of low quality, but the Institute for Healthcare Improvement and other groups have really bumped up the methodological rigor of quality improvement projects. IRBs are either reviewing or not reviewing quality improvement projects, and that varies some from institution to institution. In any of these kinds of projects, faculty might be doing quality improvement, non-academics might be doing research. It's no longer quite so clear as people used to think, that QI was sort of a thing done locally by clinicians and separate from the research that was done in academia. That just is no longer true. So here are some examples of projects that were done at CU's Doctor of Nursing Practice program, which focuses on quality improvement, and our PhD program, which trains people to do research. And you might see slight differences here. For instance, there's a qualitative study on the research side, which is probably a little less likely, although people have done qualitative methods for needs assessment and quality improvement to find out where the need is for change and how to get there from here. But you can see there are sort of tests of interventions. There are tests of predictors of care and disease outcomes. And so there may be some differences here, but they're not readily apparent to us. So I want to go back to basics in talking about this and start by talking about what is science to begin with. Here's my daughter at the science fair at her elementary school looking at salt crystals. And what science does is three different things. It wants to describe what's going on in the world around us, and the purpose of that description is often so we can predict what's going to happen next. And then hopefully, if we get really good at prediction, we would be able to influence that in some way so that we can kind of control the future. Here are some examples from studies that I've worked on. I study medication adherence, and I wanted to know, why are people non-adherent? What reasons do they give? Under what circumstances? Which people are most likely to be non-adherent? So I want to be able to find some things that then I could use clinically to predict who's going to drop out of treatment prematurely. And then ideally, we want to test interventions. What can we do to help? Now, none of these necessarily imply a methodology. I was thinking of them as research at the time I was doing them, but this question about who's likely to be non-adherent so you can target an intervention, that could be a needs assessment question. This question about what can we do to help, that could be approached in a quality improvement framework. So just by saying that something is a scientific question, we probably assume that it's related to these three goals of describe, predict, and influence, but it doesn't yet specify a particular approach to science. Every scientific project needs to answer two different kinds of questions. One is, are the results reliable and valid and actually show what you think they show? That's an internal validity question. And one is, do they apply to anybody outside of these few people that you studied? That's an external validity question. So, in a scientific sort of approach, we want to answer both of those questions systematically. Research tends to do it through randomization, randomized controlled trials, comparison groups, experimental control, strict inclusion and inclusion criteria. And quality improvement or program evaluation methods tend to do this in a more ecologically valid way that's non-randomized, that's not necessarily selecting people, it's looking at a whole population. It's maybe creating a cohort for a comparison group. You're sort of patching together some group that's similar rather than randomly assigning people and causing them to receive one treatment or another. Sort of ironically, people think about the statistical methods as going with the randomized controlled trial methods, but you need more fancy statistics to really control well for confounds in a non-randomized approach. So here are examples of each of these three scientific modalities that I've worked on. This is something that we published as a quality improvement project with one of our former DNP students, one of our grads. And she did a study in an HIV clinic where we were looking at people living with HIV and their cardiovascular risk factors, because HIV has a really high level of comorbidity with other sorts of primary care typical problems of aging: hypertension, diabetes, depression, those kinds of things. It's a complex chronic disease, and people who have HIV, their immune system's weakened even with some treatment, so they tend to get these other sorts of disorders maybe 5 to 10 years younger. Otherwise, they look similar to any other aging population with a chronic disease. So the HIV clinics are sort of focused on treating the HIV, the virus, rather than necessarily all these primary care problems. That's been an evolution for them. So her project was to get the HIV clinic to look at cardiovascular risk screening using Framingham scores and trying to get people to document the risks and the interventions that might be appropriate for this patient so that they could be counseled on some lifestyle changes, smoking cessation, those sorts of things. And the outcome was more of the patients in this clinic reached their cholesterol goals and specifically got statin medications for that. So that was the main takeaway here, is that you could provide better cardiovascular care in an infectious disease setting for people with HIV who also have these cardiovascular comorbidities. Here's an example of program evaluation. Again, HIV, this is a healthcare professional training program that I've been involved in for a number of years. We did a follow-up survey after some training, and we included 16,000 people in this, so it's a very large sample. We used some spiffy statistics, multi-level modeling using the HLM program. And we looked at repeated scores from the same trainee at different time points, so that when people came to repeated training events, we wanted to know over time, are they benefiting from that? Are they developing their skills as HIV care providers? Are they more able to reach people living with HIV and to serve them we're in a rural state, so specifically in local care settings where people wouldn't have to travel so far to an HIV clinic to get care. Can they do it right in their primary care setting? And we did show some changes, especially in testing and prevention, which were a lower incidence state in Colorado for HIV, and that's really where the care starts in a primary care clinic, is better testing practices, better prevention with people who are at risk for HIV. And then research. Here's an example about adherence. We've done this with various populations, again, including HIV, but also glaucoma and osteoporosis and other things. Only one of these studies has been a randomized controlled trial, and it was a very small one. Most of them are comparisons to a general population score on adherence, or to a non-randomized control group, or some self-report from other people who weren't enrolled in the trial. So these are not the most methodologically rigorous things in the world, honestly, but they were designed to generate new knowledge in some way. So we thought of them as research. We did statistical controls. Again, here you see the use of more intensive statistical procedures, analysis of covariance, things like that, to statistically weed out potential alternative explanations for the results. And we were very concerned about generalizability. So we wanted a population that looked like a clinical practice population that was relatively diverse, that had plenty of comorbid conditions. We didn't have strict criteria to rule people out of this study. We really wanted the patients to look like practice. So it leans more toward the external validity than the internal validity side of that balance that you always have to strike. But we were considering a research because it's to generate new knowledge. So what are some of the differentiators that I'm using to determine whether something falls into the quality improvement bucket or the program evaluation bucket or the research bucket? These are 4 suggestions. This is not all cut and dried at this point. I think this is still an evolving discussion. But these are some of the things that our local IRB does look at in order to make those determinations. So it's all about your intention in doing the research. One way to know what your intention is how involved are sort of the frontline stakeholders, providers, patients. Research tends to be top-down. It's the investigators study for their own professional interests because they want to know the answer to some question. Evaluation is usually done for the sake of a funder. Evaluation is about valuing things, about deciding whether we should continue to fund them or not. So it's about organizational goals and funders' goals and whether those goals are met. And quality improvement really is done with the patient in mind. It's intended to benefit the patient in terms of clinical outcomes. It's intended to do a better job in terms of best practices in the literature. So what we're trying to do in quality improvement is not to discover anything other than can we achieve the best possible outcomes for these patients. It's not about is this program a good program? Is my theory about how to do this well confirmed? It's about let's do whatever it takes to achieve this kind of outcome for this patient group. Randomization is another way you can guess at a study's intent, and there's an ethical reason for this. It's because it wouldn't be ethical to randomize people if you didn't have, if the treatment was known to work. If the treatment was known to work, you couldn't randomize people because you would be denying them something that's effective. So the only way to use randomization ethically is with a previously unvalidated, untested intervention. So we can infer if you used randomization, you thought your intervention was not a best practice, therefore it's research. So this seems to me like a hard and fast rule. Our local IRB doesn't necessarily agree. Standard of care is another way that you can know whether something was quality improvement or research. So research is an optional procedure. It's over and above what we would typically do for a patient in a clinic. Quality improvement is not that way. It tends to be an opt-out. If you don't want us to do this, you have to tell us so, rather than something where for research you sign an informed consent form. That's not true for quality improvement. Your consent to be in a quality improvement study is the same as your consent for treatment. I want you to do whatever you can for me to give me the best possible care to help me out with my medical condition. HIPAA regulations exclude quality improvement, so you don't need any special permission to collect or use information for it. Quality improvement is a part of care. Program evaluation is a little bit of a middle ground. You're doing it to answer a question, but the question is about the value or the benefit of the program. So it may be exempt in these same ways that quality improvement is, but that tends to be a local decision. And then finally, the role of theory. I mentioned theory in some of those examples, and a theory is something that you're testing to find out if it's really true in the real world. It tends to be something the investigator is interested in that serves their own professional goals. So if your primary goal is to test a theory, and it could be these patients or any patients, it could be this study or any study, as long as it sort of tests the postulates of your theory, then you're doing research. If what matters to you is this particular patient population and that they get the best outcomes possible, and you don't really care how you get there, only that you get there, then you're really sort of agnostic with respect to theory, and that's the perspective that quality improvement tends to take. The goal is do whatever it takes to get there, and the methods change frequently as you go based on the results you're seeing so far. So a note about IRBs. IRBs do tend to exempt quality improvement, and our process here has evolved over time, so QI does not require IRB review. What about publication? We do encourage you to publish quality improvement studies because it may be valuable to your peers. I think there's a knowledge about what actually works in practice that we need to build up more in the literature. So I really encourage you to think about all of these methods as complementary to one another, different scientific approaches, all of which contribute something to nursing knowledge, just with a different focus depending on whether it's QI, program evaluation, or research.